Welcome to the ADHD Women's Wellbeing podcast. I'm Kate Moore-Youssef, and I'm a wellbeing and lifestyle coach, EFT practitioner, mum to 4 kids, and passionate about helping more women to understand and accept their amazing ADHD brains. After speaking to many women just like me, and probably you, I know there is a need for more health and lifestyle support for women newly diagnosed with ADHD. In these conversations, you'll learn from insightful guests, hear new findings, and discover powerful perspectives and lifestyle tools to enable you to live your most fulfilled, calm, and purposeful life wherever you are on your ADHD journey. Here's today's episode. So, hi everyone. Today I'm absolutely delighted to welcome a doctor who is here to help us cut through all the noise around hormones, women's health, ADHD, and really give us some clear-cut answers because there's just so much going on out there. We've got Dr. Helen here. Now, she is a GP, she's a partner, and she's also a trainer in the north of England in Bolton. She's also a BBC Breakfast contributor, she's a menopause specialist, and she also, most importantly, advocates for neurodivergence in women and helping women understand hormonal health alongside their ADHD. You may follow her on Instagram. She's got a fantastic page on there where she really does just give us what we need to know. Lots of science, lots of research, and that is why I know that we're going to get a great conversation. So, Dr. Helen Wall, welcome to the podcast.
Well, thank you. It's great to be here.
Maybe I'll just go straight in there and ask you, what are you hearing the most when people are messaging either online or coming into your doctor's practice and they are saying either, I think I've got ADHD, or I think I'm neurodivergent, or I've just been diagnosed and I'm struggling so much with my hormones? What are you hearing the most?
The saddest thing, and probably the commonest thing that I hear, is that women don't know which way to turn and they feel dismissed and fobbed off and unheard and unseen and not listened to. There is a lot more movement now. Women are very switched on to this and they're becoming more and more switched on. But unfortunately, there's still a huge lag in standard clinical practice and what clinicians understand about this and their insight into it. And the first thing I always start with when I talk to other clinicians and colleagues and doctors is just listen. We don't have to. I think sometimes as clinicians, we can feel quite overwhelmed if we're not sure about something, or, it feels like the person in front of us perhaps knows more than we do. We might feel a little bit insecure. I'm that person in other topics as well. I'm a specialist in women's health. I'm a menopause specialist. I'm really switched on into neurodivergence and how hormones intersect with that. I'm really passionate about it. But someone might come in with a dermatology problem, a skin problem, a joint problem, and I might not be as switched on. But it doesn't matter, because really the first thing we need to do is see and hear these women, and they need to be seen and heard. And that's my biggest message to clinicians, because I hear from so many women who have battled and battled with themselves, with their lives, relationships, school, careers. They may not even have realised at the time, because they've masked so well how much they've been putting themselves through. And then they get to this point, particularly when perimenopause kicks in and the hormones start to go into flux and things start to unravel. And then they turn to someone for support and help, and they get dismissed or they get belittled or fobbed off. People say this is dramatic, but I think that's catastrophic for a woman, and it's catastrophic for a woman's mental health, for her onwards journey in that recovery of where she is, and self-acceptance, self-compassion. And I get so very frustrated with it, and that's what I'm seeking to change.
Yeah, thank you so much for your advocacy, because we definitely need it. And I hear, again, because I'm not a clinician, but I just have quite a big community of women, and I've been hearing from them and speaking to them over the years, where there is this common thread of perimenopause hitting, mental health declining, not being listened to, not quite understanding, but they've seen how their mental health has been impacted from their hormones, this hormonal sensitivity. They find out they're neurodivergent later on in life. They're able to look back where the PMDD has been there every single month. They've also struggled with other, hormonal or women's health issues, such as maybe endometriosis, fibroids, cysts. A lot of women I hear from, and maybe generationally, there's been hysterectomies and not been given HRT afterwards. it's the mental health. And unfortunately, it's horrendous to, like you say, it's catastrophic because, we're hearing more and more about suicide in midlife. And I just read a post recently on LinkedIn about a lady whose mum took her own life at the age of 49 because she had a hysterectomy and then wasn't given the hormones. And we need to build more awareness, create more awareness around this, about this intersection of neurodivergence and not getting the hormonal balances right. I've seen it in my family as well. And I want to ask you, again, I'll use myself as an example. At the age of 41, I started noticing my perimenopausal symptoms. I could see that perimenopause hit early on in my family life. This has been
Mhm.
validated by doctors, Dr. Sandra Coy, who says that perimenopause tends to hit earlier and harder in neurodivergent women. And we need to change the narrative that it's not too young, late 30s, very early 40s, to go and inquire about hormonal help. Can you give us a little bit of an insight as to why we're still getting this pushback from clinicians?
Yeah, I mean, it's fascinating, isn't it, why we're in this place really, and I think, we could have a whole different podcast about how women are misdiagnosed, dismissed, mistreated in terms of the whole picture of medicine throughout the ages. It dates right back to the term hysteria, when women were, classed as having a wandering womb that made them anxious and agitated. And, we've been sort of almost belittled for a long time in medical. Some people call it medical gaslighting, and I think that's quite a strong term, but it does ring true in some things that we see. But I think there's a whole piece of the jigsaw missing for many clinicians here that we really haven't put into standard clinical practice yet. We spend a long time as doctors at medical school, training afterwards. We learn about nerves that we never ever see again, and muscles that we never talk about again, but we don't talk enough about the effect of hormones on the female brain. As far as medical students, by and large, doctors are concerned, female hormones are talked about in terms of periods, puberty, fertility. They're not talked about in terms of mental health. And actually, we know there's very clear research and neuroscience evidence to show that the female hormones have a huge impact on our chemical messenger systems within our brain. So they affect our serotonin levels, our noradrenaline levels, our dopamine levels, glutamate, GABA, the list goes on. So it's no surprise that we are affected mentally by fluctuating hormones. And I don't think that's thought about nearly enough, or within the education system amongst standard practice. And that's one thing that I really sort of hone in on when I'm talking to colleagues and doctors. We have to get this into our day-to-day language.
To me, from an outsider, it's so, I mean, I guess I see the bigger picture. I'm not in the nitty gritty. I know that the pressure on GPs is
Oh, I know that,
huge at
yeah.
the moment. But from an outsider's perspective, I see women, and I guess I've got a bit more of a radar, like I can sort of spot ADHD and neurodivergence, and someone gives me like a bit of a family picture, and I'm like, oh, okay, and I can sort of see it from all angles. And what I don't understand is why we don't have more awareness in GPs to almost be able to spot this neurodivergence in women. We need better awareness to ask those nuanced questions to discover, okay, where's this anxiety coming from? Where's the depression? Where are the hormonal imbalances or the very, very debilitating hormonal fluctuations?
Absolutely, and I think this is multi-layered. ADHD for many clinicians is still a childhood condition. It's not really, the services are not fully there yet in terms of adult ADHD. It's not recognised as a thing. I think there's a huge male gaze on the diagnostic criteria of ADHD. So, even now, if I ask some colleagues, what does ADHD mean to you? And we're talking about very experienced colleagues, doctors, clinicians, GPs here, they'll say it's the disruptive child in the classroom that's throwing things about, that's in trouble. I had a lady actually say to me that another GP had said to her that she couldn't possibly have ADHD because he went through a few questions, and a couple of the questions were, have you ever been in trouble with the police? Have you ever had a drink or alcohol problem? And this lady was a very high functioning lady. She had a great career. She was top of her tree. She had, seemingly to everybody around her, really, smashed life. But internally, she was burnt out and she was really, really unraveling. And this is not well known about yet in the medical community. I don't think. I don't think that we've got it out there yet properly. That women can look and seem completely and utterly in control and flying in life, and actually internally be struggling and masking and burning out. And it links back to that thing I was saying about us not joining the dots with the hormones on the brain, with ADHD being actually quite common in women in terms of different symptoms to what we'd expect in the behaviorally disruptive child in the classroom. And I think this issue around us seeing women a lot younger now in their perimenopause journey is also key in that. So you can see there's multiple bits to this jigsaw. So even 5-7 years ago, we talk about before COVID and after COVID, don't we? So that cutoff. If I think before COVID, it was very unusual to see a woman in her late 30s, early 40s coming to me saying, I've got all these symptoms and I think it might be perimenopause. We tended to see, by and large, women who either had stopped their periods or hadn't had a period for 6 months, 9 months. They were very scatty and they were very much in the throes of full on menopause, or, coming up to that point of menopause, because, of course, menopause is when you haven't had a period for a full 12 months. We looked at menopause with a whole different viewpoint. We looked at it as hot flushes, night sweats, feeling really hot and bothered, occasionally a bit of mood swings and mood instability thrown in. We didn't really talk about the bigger picture, which is joint aches and pains, brain fog, memory issues, feeling completely out of your depth in normal day-to-day life. We didn't recognize that because, again, we hadn't factored in the effect of these hormones on the female brain. So we're not joining up the dots. We've got all these bits of information. We've got evidence that says dropping estrogen can affect our brain chemical messengers, which can affect our memory and cause brain fog and all the rest of it. We've got information that perimenopause can be wider than hot flushes, hot sweats. And we've got information that says that ADHD is not just being impulsive and disruptive in the classroom. It can be inattention and internal restlessness. But nobody's joining these dots together and nobody's presenting this in a whole picture. Well, people are, but not in not in day-to-day standard clinical practice. And I guess that's in part what I do with my Instagram. I try and fit all those pieces together and say to people, look, this is an actual diagnosis. This is a picture. This is what we see commonly. I've seen these women. And interestingly, I've seen women like this that I can think back to even before I started to recognize this sort of 10 years ago. I can still think of women 10 years ago that I saw time and time again in my GP room where I hadn't joined up the dots. And I feel incredibly sad about that, incredibly sad, because if I had joined up those dots, then that woman may have had a completely different journey. And, if I'd given her some HRT or supported her in her menopause journey, if I'd recognised she might have ADHD and got other support for that, then, her whole life course could have been completely different. And unfortunately, I'm probably a little bit ahead of that curve now, but there's lots of clinicians that hopefully in a few years' time will be saying, if only I'd joined those dots sooner. But what we need to do is speed up that joining of the dots process. And that's sort of where I am on all of that.
Yeah, and I think, listen, to give you compassion, you only know what you know, and this is such a new area, and we need that research coming through, and we need a real focus to help educate the clinicians who are the ones who are the gatekeepers to the HRT, the sending people for
Absolutely.
diagnoses. And, I always use myself as an example because I don't care about sharing, but, I was offered anxiety medication before my ADHD diagnosis when I was 40. And I knew that there was something else. And that's when I got my diagnosis, long story. And I knew that it wasn't anxiety medication that I needed. And thankfully, I had a doctor who did listen, but she was also very uneducated in this area. She even, she held her hands up and went, I don't know enough about this. And I had to go and self-advocate, which was really hard work. And a lot of women don't, they're coming at this late 40s, really in the throes of perimenopause, rock bottom, mental health on the floor, relationships broken down, looking after neurodivergent kids, struggling with hormones and mental health. And I see these women and I'm like desperate to help them. And then there's also, let's go into the nitty-gritty of the hormones. Thankfully, menopause, we're talking about this now. There's a lot going on in the media, and thankfully we've got, all sorts talking about it, but it's still very estrogen led. And I've done a lot of work with Adele Windsor, lots of podcasts and workshops, and we want to talk more about the progesterone and helping women understand that they think there's a progesterone sensitivity, and understanding that there may be the progesterone sensitivity has been with synthetic progestins, on birth control, different types of contraception they've been on, but actually understanding the connection between the GABA and the progesterone, and helping women understand that it helps with anxiety, sleep. They may need a lot more progesterone than they've been prescribed by their GP. And understanding this hormonal sensitivity, our sensitivity as neurodivergent women, I see ourselves, and I know that Paula Rastrick talks about this, the trauma, the sensitivities that are in our body that goes into our hormonal pathways, our nervous system. And again, I'm not a doctor, so I use these words, but I don't understand the intricacies of it. But I see this bigger picture. I see it anecdotally. And I want to help more women self-advocate. How can they ask for a different type of prescription that's more personalized than this one approach that all women are getting from, I guess, doctors who aren't aware of neurodivergence and these hormonal imbalances?
Yeah, absolutely. And I think obviously we're here to talk about neurodivergence, but I think this is the case for all women. There is such a huge spectrum in how women respond to progesterone or progestogens. We can't get away from the fact that there are a number of tangible reasons why one lady may respond completely differently to the next lady in terms of a progestogen. For example, women can have different receptors, progesterone receptors in their body. They can have different levels or components of enzymes that break down that progestogen. They can have, genetic reasons for those things that happen, that their own underlying hormones can interact with how they are metabolizing hormones that we take in. So, there's a whole list, and I talk about that on my Instagram, the tangible reasons. And it's interesting you should bring this up, because earlier on in the week, I went to do some education for some GP colleagues. And I was talking about this because I think there is this mindset that micronized progesterone is good and synthetic progestogens are bad. And I don't think that's necessarily the case. I don't know what people who've been here before have said, but I think it's all about what's right for the individual woman. It's not about good and bad. What's right for one will not be right for the next. And we know that women with neurodivergence are often very sensitive to different progestogens, and they need tweaking. And I think what we need to say to clinicians as a whole, that the training I was doing earlier on in the week, is that there is no one size fits all for this. Yes, most women, or many women, will feel better with micronized progesterone. That's your Eutrogestin, your Gepratix, the one that you take at night as a capsule. But it's not a set in stone thing. Some of those women might feel better with a different type of progestogen. And what really, really frustrates me, I've got a lot of things that frustrate me around this, but one of the other things that really frustrates me is when I hear from women, I do a menopause clinic, and very often those women have been through their GP or they've seen other clinicians, and then I sort of see them if they're a bit more complex, or so they get referred on to me as complex cases. And actually, they're not always that complex. It's a case of, they've been told, well, HRT just doesn't work for you. It just doesn't suit you. You get too many side effects. And actually, when I speak to these women, by and large, they've tried one HRT, they've tried one progestogen, they haven't tried different things. And my message to the clinicians that I was talking to early on in the week is, don't give up on these women, and equally women don't give up on HRT. There's obviously a lot of women that can't take HRT. There's a lot of women that don't want to take HRT. Kudos to them, absolutely fine. But if you are keen to have HRT, you have to just keep going, and there's a trial and error approach to this. Yes, there might be one that we think will work better for you, and that's often the more natural micronized progesterone. And as you said, some women actually need more of that. Some women actually get this kickback where it activates the GABA in the brain, which is our calming chemical messenger. It's the response that you get if you have that glass of wine on a Friday night and you suddenly feel relaxed. It's the response that you get from sedatives, from sleeping tablets, from diazepam. That's what activates your GABA receptors initially. So some women do get that very calming effect from progesterone, but some women, particularly neurodivergent women who have an altered response to that can actually feel worse on it. So it's just sticking to that mantra of there is no one size fits all, and what works for one woman may not work for the next.
Yeah, I think it's the understanding how they can ask the questions. And I understand, how, over there's this sort of difficulty in the NHS, I guess, to get this more personalized approach due to time. And maybe, just having that time with a GP who is as aware as you are. Um, and I hear from so many women going, well, I don't know what to do now. Like my GP doesn't understand, and I don't think my HRT is working. They don't understand about estrogen dominance, or that I do need to up my progesterone and I only need, one pump of estrogen, or I need to change it and tweak it throughout my cycle, or I need to understand how that interacts with my ADHD medication. And we are low on understanding.
We're low on evidence as well, and we're low on
Mm,
studies that support this, and that's the problem. If something has a lot of evidence and research, but it's not within the guidance, then clinicians, by and large, you can sell that to clinicians. If, it's in the guidance, you can sell that to clinicians as standard clinical practice. At the minute, we're in a very difficult place because there is no real guidance on how we manage women who are neurodivergent and hormones, because there is no backstory to that. There's no evidence and research, and it's very, very under researched area in what I've looked at. So I think it's really difficult, and some of the terminology as well is quite challenging because some of this terminology is not recognised. Like estrogen dominance is not a recognised term by the British Menopause Society, who I sort of follow and a specialist with. It is easy for clinicians to feel very bamboozled by the different terminology that's coming out and the different things that women are hearing and seeing. And I think it's easy for women to get sucked into some of that as well and not know what is right, what is real and unreal, and what they should be advocating for, in terms of advocating for themselves.
So can I ask, because like you say, we haven't got that research, and it has to be, as clinicians, you have to follow these guidelines, which I totally understand. There's huge risk if something goes wrong. But are you seeing neurodivergence in women, especially this topic, is more patient led? We've got anecdotal evidence, which
Yeah,
is way,
absolutely.
way ahead. We know the DSM-5, the way it describes ADHD, especially in women and girls, is so behind. It needs updating. I think the British Menopause Society, I don't know how often it updates its clinical evidence, but I think it's behind. And is there a way of clinicians understanding in this particular sector, it has to be more patient led or trial and
Yeah,
error?
look, I'm not by any manner of means saying that we have to follow guidance. We are clinicians and we are trained and we're experienced over many, many years, many of us. And, we shouldn't be following guidance just because it's guidance. That's absolutely not what we should be doing. But I guess what I'm saying is, if you are GPs by and large are not specialists in menopause, and I get a lot of comments on my or hormones, and I get a lot of comments on my Instagram saying all GPs should know this and all GPs should be able to do this. And I disagree with that because actually we are specialists at being generalists. We know a lot about many, many things, but we don't know the in-depth and granular detail of things unless we've chosen to take time out and put training into that. I mean, I took time out of practice on my annual leave. I've done this in evenings, I've done it on weekends at the detriment of missing out on my 3 children and things they were doing. I've paid a lot of money to take on this extra training. We can't expect all GPs to do that. I did it because I'm very passionate about it and I'm interested in it. I think the difficulty is that you're not going to get a GP that is necessarily so comfortable and experienced in dealing with this that they're willing to divert from the guidance, and that's the issue. So no, we shouldn't be following guidance rigidly because it's guidance, but in order to deviate from guidance, you have to have a certain level as a clinician of comfort and experience and knowledge, and be experienced in these anecdotal stories that you're getting from patients enough to feel that you've got enough to go on to deviate from that guidance. And the majority of GPs, if they've not taken time out and specialised and trained in this, will not be in that position. So when they meet a patient and they're unsure what to do because they haven't got the experience or the knowledge, they will deviate to guidance and they will follow guidance. And I don't think we can berate them for that because that is their safe place and that's what we expect them to do. That's what I would expect my GP trainees. I always have at least one trainee on the go in terms of training them in practice, I would expect them, if they got to a position where they met a patient and weren't sure what to do and didn't have that experience or knowledge, to deviate to the guidance and to follow that guidance because that's a safe place for them. I might think, well, that's not right for that patient, so I'll try this because I've got evidence of this or experience, but we can't expect all GPs to do that. And I think that's where we're at. So what we need to do is almost like there's two parts to this, isn't it? It's empowering women to advocate for themselves and to keep not feeling bad about going back and asking for more, but also to empower clinicians to learn more about this and experience more and become passionate about this because it is a great area to work in if you do ignite that passion because you can literally change and save lives. We've already spoken about the detrimental effects of perimenopause. 1 in 6 women in perimenopause, regardless of their neurodivergent or neurotypical, have had suicidal ideation. And that's huge, and we need to really focus on that and make changes.
So, what if understanding your ADHD was the key to having the life that you truly deserve? I want to tell you a little story that when I was diagnosed with ADHD at 40, I genuinely couldn't find the support that I was craving, that I needed, nothing that acknowledged both my neurodivergence and this need for my well-being to improve. And that's why I started this podcast. And I also have written the ADHD Women's Wellbeing Toolkit, which is now out wherever you want to buy your books or audiobooks. And it's the compassionate, practical resource I wish I'd had 5 or 6 years ago when I was initially diagnosed. It's a holistic guide for people like you and me, combining our lived experience, my lived experience, expert advice from many of the guests that are on this podcast, and empowering tools for navigating the many symptoms and traits that we experience, such as anxiety, RSD, fluctuating hormones, burnout, but also learning ways to lean more into the creativity and joy, which help us grow as neurodivergent women. So currently, we understand that ADHD is affecting nearly 3 million people in the UK, yet up to 70% of women remain undiagnosed. I really hope that this book helps you make sense of your experience, whether you're newly diagnosed or waiting on this very, very long list. And as my publisher DK puts it, that although Kate's book can't shorten this very long NHS waitlist, it offers something practical and empowering to do so while you wait. It's a source of comfort, community, and championing time and time again. I just want to let you know that the book is now available, so please do grab a copy wherever you get your books. Now back to today's podcast. And, you talked about you get sent the complex cases, and I'm just interested to know the complex cases. How many of these women, I guess, maybe percentage wise, do you sense as neurodivergence there? And before you answer that question, I want to bring in the different maybe traits that I see in women who have only found out they're neurodivergent later on in life. And I often hear that they've had endometriosis, PMDD, cysts, fibroids, mental health conditions, OCD, addiction, this picture. And I wonder, the complex cases that you're seeing, what percentage would you say encapsulates this?
It's difficult to put a percentage on it, isn't it? But I think if you're seeing somebody who's been through other clinicians and perhaps not got quite, got the answers that they need, I probably do see a higher percentage of women who are neurodivergent, which is perhaps what led me down this path to be so passionate about it. Because I've met a number of women over the years who you just think, there's something else here. There's something else going on. These hormones are wreaking absolute havoc out with what we would expect. And I have, directed a few of those women through ADHD, particularly ADHD pathways to be diagnosed. I would say probably a 20%, if I was going to put a figure on it. It may well be higher. I think one of the key things that we need to get out to clinicians is if you are recurrently seeing women with anxiety and depression, mental health disorders who are treatment resistant, i.e., you're doing all the things that you would do with any other patient, therapy, medication, etc., and they are not getting any better, then think about underlying neurodivergence because the anxiety and depression, it can obviously coexist with neurodivergence. It's more common in women who are neurodivergent, but is it a symptom of the underlying neurodivergent, or is it the diagnosis? And I think we're not very good at separating the two and recognizing that it could actually be an underlying reason. And then obviously perimenopause lands on top of that, and the hormones go all in flux, and then that just compounds everything, and everything implodes. So yeah, I do see a lot of women where, they've had this history of often treatment resistant anxiety and depression, but often they've really coped, and seemingly on the to the outside world, they've really coped and flown in life, and then everything's come crashing down. And it is a really, it's a really hard thing to watch happen, and we need to be better at recognizing it and understanding it, I think, as clinicians.
Yeah. And my last question to you is, and I'm not sure if you'll have the answer to this, but my question is, say a woman who is below perimenopausal age has consistently had PMDD and really struggles. Why are we not able to prescribe types of hormones instead of it being, anxiety medication or antidepressants, progesterone or topical progesterone, vaginal progesterone? If we know that the PMDD is hormone led and obviously it's impacting our mental health, why is that not a prescriptive pathway and why has that not been considered?
It's a great question, and it's one that I often mull over. And I think it goes back to that previous point I was making. We just don't have the framework to hang that off. So I think, we're just not far enough along that journey of joining up those dots. So, the more passionate and involved amongst us will know that there is significant impact of women's hormones fluctuating on their brain and their mental health. But it was 2023 before there was a study done on how hormones can impact on perimenopause mental health. 2023, so just 2 years ago, before the first study was pulled together on this, exploring mental health in perimenopause. I mean, just let that sink in. We're in a world of AI and, all the other high flying technology things that are going on at the minute. You can order something on Amazon and it be delivered the same day, but we have only just started to join the dots between the effects on the brain of women's hormones and put it out there into clinical practice. So I hope that that will become standard clinical practice in the future. But these things take time to come to filter through, to embed, for the research to be there to back up putting it into standard clinical practice. And that's the difficulty that we're in at the minute. So there are a few doctors out there who are doing this, but they are, I suppose, I don't want to say going off piece, because it's not that I disagree with it, but they're working out with sort of standard clinical practice. And it's difficult for the day-to-day clinicians who are not specialists in that area to do that, I guess.
Yeah. Listen, thank you so much. I know you've got a busy GP practice to get back to. My last thing, what would be your parting message to anyone who is nervous to go to their GP, who or has been sort of maybe fobbed off or dismissed or told that this is just the HRT pathway to go with? How would they then go back with confidence and self-advocacy to really get what they need?
Well, look, I think it's really hard because at that particular point in time as well, because we've just talked about all the ways you may be feeling, your life may be imploding around you, to then say, oh, you just need to have confidence and go back. That's like just telling an alcoholic not to drink beer. It's difficult. But I think, the work that we're doing here is just to really empower women to say it's not you, it's them, kind of thing. It's okay to question, even medics, question them, go back, just keep going back, because actually you need to advocate for yourself. We're just not because the doctors are bad or they don't care necessarily, it's because we're just not in that place of full understanding and acceptance of these issues, and we've not yet joined up the dots in standard clinical practice. And until that happens, I'm afraid women are going to have to just keep going back and advocating, and it doesn't make it right, but I'm being completely honest about where we are.
Yeah. I appreciate that. And thank you so much for sharing your advice, your guidance, your insights. I know this is going to be very, very helpful. So, really, really want to thank you, Dr. Helen Wall. And if people want to find you, they can go to your Instagram, which is
The full word, Dr. Helen Wall. Yeah. Thank you.
fantastic. Thank you so much, Helen, and I'll speak to you soon.
Thank you.
If this episode has been helpful for you and you're looking for more tools and more guidance, my brand new book, The ADHD Women's Wellbeing Toolkit, is out now. You can find it wherever you buy your books from. You can also check out the audiobook if you do prefer to listen to me. I have narrated it all myself. Thank you so much for being here, and I will see you for the next episode.